The next area that potential problems that could occur is hematoma. I create a space where no space exists. You could bleed into that space. How do we eliminate that? Number one, endoscopic surgery. We see the bleeder, we stop it. Number two, drains. We get rid of that last little bit of blood that's oozing out of capillaries. Number three, my patients take it easy for 3 days, for 72 hours. They don't wash dishes, they don't make beds, they don't drive a car. But at the same time, they don't lay in bed and do nothing, or they'll get clots in their legs. So you're housebound, but you're not bedbound for 3 days. The third potential complication area is malpositioning, breast implants that are too high, too low, too far to the sides. And remember, I told you that if I have a complication, I have to fix it on my dime. And as much as I love my patients, I prefer not doing free surgeries. Therefore, I never let the patient leave the operating room until the breasts are symmetrical. And I've got this magical instrument. It's called a ruler. New thing. You may not have heard of it. Anyhow, yeah, just kidding. I have a metal ruler, and I measure from the bottom of the breast to the nipple. Now, two breasts very often are not exactly at the same position, and we make them as close as possible with keeping the nipples looking good. Normally, and I discuss this with my patients, normally we want the nipples as much as possible on the same level, not the bottoms of the breasts. So you can't get everything, so we go for the best look with nipples at the same level. But if the implants or the breasts are malpositioned more than they should be, tiny bits of asymmetry that aren't acceptable, then they have to be fixed, and I fix them. The next potential area is loss of nipple sensation. Again, nipple sensation comes from a nerve that comes from here laterally up to the nipple, and it's the between the fourth and fifth intercostal nerve. And that nerve is very often injured when you make an inframammary incision. It's sometimes injured when you make a periareolar incision. It's almost never injured when you go in through the armpit. So going into the armpit underneath the muscle gives you the greatest chance of no loss of sensation. And I have a very great track record of not losing nipple sensation. And it's because of the route of entry, because we handle tissue delicately, and because it's just the right way to go in. All of these problems that I've just discussed basically don't happen. That leaves two potential problems. And number one is leakage. Implants that leak have to be redone. Saline, and final area that I'd like to describe for you in complications are hard breasts. Well, do the implants go hard? Of course they don't. They're immutable. Implants are inorganic. They're not organic. They're not human. They're not living. They don't change. The body's response to a foreign body is to form a scar around it. If that scar is thin and fine, then you've got soft, jiggly breasts that do everything you want them to do. If that scar is thick as shoe leather and very hard, then you've got two tennis balls on your chest. Well, how do we deal with this? Now, the old way of dealing with it, which never worked in my opinion, was the breast massaging, moving them up, moving them down, moving them around, laying on the floor and rolling on your breasts. That's a mechanical approach to a biochemical problem, and it won't work. I did a little study when I was at Stanford, and I looked at the women who had breast implants that went hard. Half of them did massaging, half of them didn't. Half of the ones that did massaging got hard, half of the ones that didn't do massaging got hard. So I concluded massaging makes no difference. So what does make a difference? Dealing with the problem. And the problem, you've got some etiologies. In other words, what leads to hard breast? And then you've got to deal with the hard breast. Okay, the two areas, the two things that we know about hard breasts are one, capsular, or hard breasts are capsular contracture. the first area is blood around the implant. You do not want blood around the implant because it'll lead to a hard breast. The body converts that blood into thick collagen, and then you've got a hard breast. How do you get rid of that? One, you do a very neat surgery. Two, you wash out any blood that may be in there. Three, you do it endoscopically so you can see every little bleeder and stop it. Four, you put a drain in to drain out whatever excess or minimal bleeding there is so you get a very dry field. And five, of course, as I mentioned before, you have the patient take it easy for the first 3 days. Decrease blood around breast, much less chance of hard breast. The next thing, and this is very well studied and very well described by lots of authors, is bacteria around the breast, but not the pathogenic bacteria that will cause pus and an infection, but non-pathogenic bacteria. Human beings live with bacteria on our skin all the time. It's called staph epidermidis and strep coagulase negative. It's not the kind of bacteria that leads to an infection, but once it gets inside, your body reads it as a foreign body, an invader, and it attacks it by putting out an immunoglobulin to create more collagen to wall off the bad invader, which is the non-pathogenic bacteria. How do we get that inside of us that sets off this problem? And the answer is, if you've ever seen a doctor try to force an implant into a pocket, I've done it too many times. You push, 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 you're dragging all the bacteria off the skin. That then gets inside, and for the patient that's going to respond to that, you end up with a hard breast. Dr. Keller, and I usually don't advertise anybody, but this was brilliant. Dr. Keller invented a funnel, and it looks like something Julia Childs would decorate the top of a cake with. And if you drop the implant into that funnel, now it drops sterilely from a sterile box into a funnel, that then goes directly into the pocket and then directly underneath the pectoralis muscle, and you never touch it. It's a no-touch technique. The Keller funnel plus drains plus endoscopy leads to very soft breasts in well over 90% of all patients. Implants have a valve, which is the #1 reason for all implant leakage. And so silicone implants don't have valves. Another reason I don't like saline implants. Finally, silicone implants, there's a YouTube video showing a monster truck running over a silicone implant. They don't break. Therefore, leakage is very, very, very rare. A much better implant. However, if the implants leak, the manufacturer will give you 2 new free implants for the rest of your life. Usually, I must say, people tend to go bigger on the next, on the redo. If they have implants that break and they get free implants, they usually go bigger. And you get 2 free implants, and usually for the first 5 to 10 years, they even give you some money towards the price of a redo.